Good afternoon, everyone. Thank you so much for joining us for RUI Informed. Those of you all that have been here in the past, we welcome you back, and our newcomers, we welcome you too. RUI Informed is our RUI University online lecture series for families and residents in our community surrounding our local senior living. We are very excited today to have our very own dementia education specialist, Ashley Staton, who has a MSW, a master's in social work, and works with BCU College of Health Professions. And more excitingly, she is an expert because she works with the gerontology and the Virginia Center on Aging. And you know what? I'm going to tell you a little more about Ashley. We welcome Ashley because Ashley serves as a social worker on the Virginia Memory Project. And those of you familiar with the state of the Commonwealth of Virginia know that there's a 24 to 26 dementia plan. She provides interested BMP enrollees with a sensory memory screening and our resources to refer for formal services provided by the Richmond Brain Health Initiative and other qualified health professionals. Her work is dedicated to ensuring older adults within Virginia have access to equitable brain health, memory, and caregiving resources. Now, she holds a bachelor's degree in psychology and African American Studies, but a Master's of Social Work and a certificate in Aging Studies. So, aging in place, aging well. Ashley, I cannot say any more than thank you. Thank you for bringing your expertise to our local visitors this evening, residents and families. Welcome to RUI Inform, and on behalf of the entire RUI community, thank you for being here today. I'm going to turn it over to you now. Thank you, Ashley.
Thank you, Cleo. Thank you for that lovely introduction. And again, thank you for having me here. It is such a pleasure to connect with the community anytime I have a chance. And today I get to talk about something that a lot of people who work with older adults may experience, and that is the three Ds, dementia, delirium, and depression. And so I will get us started, hopefully. So Cleo already did an amazing job summarizing what brings me to the table. I am a gerontological social worker, which means all my work is dedicated to older adults and their families, whether that's advocacy, education, direct service. I'm here for the people. I'm also a certified dementia practitioner, which means I have a lot of education and knowledge when it comes to working with dementia and what that looks like in the physical and psychological form. And I work for the Virginia Memory Project, which I will talk about a little bit later. But essentially, that's our dementia registry. So all my work focuses on older adults and specifically with dementia, which is a really big thing. So we're going to hop into it. But before I start breaking down why we talk about the three Ds and what they are, I want to give us a framework. And so, a big part of the aging community, as you know, we're all aging. The aging population will grow greatly over the next 20 years. And so, a part of understanding that population and the way that the world will look in the future is this concept of age-friendly care. And age-friendly care really focuses on two things, and that's person-centered care, which there's a beautiful definition on the screen, but essentially, that means we listen to the client, we listen to the patient, and we make sure that their concerns, their desires, their expectations are what is at the forefront of their care rather than what we as family members or healthcare professionals think should be done. So, focusing on the person. And what really feeds into that is this four M's framework. And so the four M's, and it's actually five M's, but I haven't updated my slides yet. But the four M's is really this framework that allows us to really understand what is important and what does age-friendly care look like. So the first M is what matters. And again, that ties directly to the person-centered care of what matters to the patient that we're working with. What are their goals? What do they look for in their healthcare experience? And that should be what really guides us in all the work. So that's the first M. The next M is medication. As we talk through this presentation, there will be a lot of emphasis on medication. But really, when we look at the framework, it's making sure that those medications are necessary, that they fit the needs of the patient, that we're not over prescribing, and that we're being mindful of what medications are a part of a patient's care. The next M is mentation. And that's pretty much why we're here today is to prevent, identify, treat, and manage the symptoms of the 3Ds across healthcare settings. And finally, there's the mobility. And that's just simply making sure that everyone, including older adults, have the ability to move safely and freely in whatever setting that they live in. And so I'd like to present this part first so that we have a good framework as we talk about the 3Ds to understand why it's important and why this work matters. And really, it focuses on making sure that the needs and the expectations of the patient are what we put first. And so, why do we talk about the 3Ds? They overlap a lot. They are very common in older adults. I know a lot of people tell me when they think about dementia, they think about older adults. And so all 3Ds are very common in older adults. And so we want to make sure when we're working with this population that we're aware of things that happen to them on a regular basis. They have shared risk factors and they look the same. As we talk through, you'll kind of see the similarities between the 3Ds. And so it's important for us to know what they look like separately and as they overlap. And they can be cyclical. And what I mean by that is sometimes a person with delirium may be more susceptible to experiencing depression. A person with dementia may be more susceptible to experiencing depression. A person with depression may be more susceptible to experiencing delirium. So they kind of feed into each other. And again, that's why it's so important for us to understand or have an understanding of what they look like separately. So, now you know the framework and why we talk about it. We're going to hop into the first D, and that is dementia. Oftentimes, when I ask people what do they know about dementia, the answer is it's a memory loss. And so I like to call it the same thing. It is an umbrella term for the loss of memory. So there are different types of dementia, and this picture here kind of gives you an outline of what those different types are. This is only a few, but there are over 300 types of dementia. And they all have this baseline thing that makes it present as dementia. And it's that change in memory and thinking. And it's not little changes, it's very pronounced changes, changes that make it hard for a person to live and function in their day to day. That is what I like to say dementia is. And again, it's an umbrella term. So the one that we are most familiar with is Alzheimer's, of course. About 80% of dementia cases are Alzheimer's. But I will talk about it as a whole. And to get us started, I like to give fun facts. And they're not really fun, but they are facts. Um, Dementia kills more than breast cancer and prostate cancer combined. It is the seventh leading cause of death in the United States. And a lot of people are very surprised by this, but when we think about the age of our population, it kind of it kind of makes sense. There are 7 million Americans living with Alzheimer's disease. Um, and that number will only grow as time passes. It has a larger impact on certain populations. So for the Black population, it impacts them 2 times more. In Latino populations, it's about 1.5 times more. And it's more prevalent in women. About 2/3 of cases are in women. Dementia care costs a lot of money, and that cost will continue to rise to about 1 trillion in 2050. And something that I always like to bring to people's attention is that Over half of healthcare workers believe that the system is not built or equipped to deal with this disease. What we know about dementia has changed a lot over time, and it continues to change. And so that brings a little insecurity, a little uncertainty about how the system works with dementia. And so now I'm going to start us off with a short video, and hopefully you guys will be able to hear it about what dementia might look like in an everyday citizen. So,
Long career in the military, Mr. R sustained a number of. Mr. R is an 81-year-old recognized war veteran. With his long career in the military, Mr. R sustained a number of injuries, the most significant being a head injury. Mr. R is over 6 feet tall with a large build. After retiring, he became sedentary and gained weight, eventually developing hypertension and diabetes. He was prescribed antihypertensive medication and oral medication to control the diabetes. About 3 years ago, Mr. R started struggling with his memory and judgment, including writing a check for $40,000 instead of $4,000, driving into a parked car, and getting lost in his neighborhood in his pajamas. He was diagnosed with Alzheimer's dementia, although the doctor suspected it might be mixed dementia, given the cardiovascular risk factors and history of head injury. Despite the diagnosis, Mr. R continued to enjoy spending time in his workshop, listening to the radio, and socializing with friends. Since his dementia diagnosis, Mr. R has remained at home with his wife. Mrs. R has been actively involved in helping Mr. R navigate the dementia diagnosis and has managed his medical needs, administering medications and monitoring his blood sugar. Lately, however, Mr. R's personal care and medical needs have become too much for Mrs. R to manage. Furthermore, the diabetes has become poorly controlled, requiring more frequent glucose monitoring and insulin. He requires more assistance with toileting and dressing and has become suspicious and easily angered. One time, he pushed Mrs. R away forcefully, and she almost fell down. The decision was made to have Mr. R move into a long-term care home to best meet his changing needs. Upon moving to the long-term care home, he appears restless and suspicious. He tells the staff to go away and calls out for his wife. During personal care, he repeatedly asks for his wife. He appears disinterested in eating and pushes the food away. The care team meets to discuss how to best care for Mr. R, given his progressing dementia and changing circumstances. Mr. R is an
so I played that video so you can get a quick summary, a quick glimpse of what dementia might look like for someone. Um, the video mentioned a few symptoms that I have listed here. One of the big ones that people like to bring up, and I'll kind of go out of order a little bit, is that decreased or poor judgment. So the video talked about Mr. R writing a check for the wrong amount and driving around in the neighborhood and kind of losing his navigation. So those are some very big pronounced symptoms, and I'll kind of run through the rest of them that I have here. Again, I like to emphasize for every time I talk about this, it is memory loss that disrupts your daily life. It is not, I can't remember where my keys are 5 minutes ago. It is very much so not remembering how to write that check, not remembering how to get home, not remembering what your name is or who a family member is. It's very pronounced and very disruptive. Challenges in planning or problem solving. Again, I'll go back to the video example, the writing of the check or not being able to complete a puzzle like they used to. Difficulty completing familiar tasks. Again, the video mentioned him writing a check, driving, not remembering a recipe. Those are really good examples. Confusion with time or place. When someone can't tell you what year it is. when someone can't tell you what the date is, um, just those big pronounced confusions, trouble understanding visual images and spacing. The example I like to use is driving. This is when someone can't recognize a stop sign or they don't remember the distance between cars. Those are really big examples. New problems with communication. A good example of that is when someone can't follow along in a conversation or they're less engaged in a conversation. The misplacing things, the decreased or poor judgment. Another big one is withdrawal from work or social activities. And some of these, as we move along, you'll see how they overlap with the other Ds, and that will be one of them. And then changes in mood and personality. I think the video mentioned that Mr. R was a calm man, and once he moved into the residential setting, he started becoming more aggressive, more suspicious. So big pronounced changes in mood and personality. Someone who is normally calm is now aggressive, or someone who is normally aggressive is now extremely calm and non-responsive. And again, dementia looks different for everyone. So someone with dementia may experience some of these, they may experience all of them. It varies depending on the case, but these are the top symptoms that we look for when we think about dementia. Dementia does not have a cure. Dementia is not preventable. But there are things that can lower your risk. And so what I have here are about 8 to 10 different modifiable risk factors. And so what that means is these are changes that someone can make on their day-to-day that impact not only their brain health, but their physical health as well. And so a lot of that looks like being mindful of your cholesterol and your blood pressure and your weight, making sure that you stay physically active, making sure that you are not consuming too much alcohol and not smoking or not smoking as much. Other ones include staying socially active and not isolating. If someone experiences depression, making sure that they receive treatment for it. Other ones can look like hearing loss and vision loss. And so it's just about making sure that you're mindful of how your body is functioning and actively addressing any changes that occur. So there are treatments. Again, it doesn't necessarily get rid of the dementia, but it does manage and treat the symptoms. And I break this down into pharmacological or the truly medical treatments and then non-pharmacological. And these are things that don't require medicine, but do require some support and a little bit of effort. And so on the left, you'll see different types of medicines. Again, these don't necessarily treat the dementia itself, it treats the symptoms. And so there are sleep aids, anti-anxiety, antipsychotic medications. There are medications that are marketed to specifically treat dementia symptoms. And I'm sure we've seen commercials or ads about those. And so some of them are listed here. And for the non-pharmacological, I really like to focus on those psychosocial interventions. So that means doing activities with a person, making sure that they don't get isolated, making sure that they do stay engaged. This might be puzzles, this might be taking them to a craft class, this might be music therapy. There's lots of different things to ensure a person with dementia stays engaged. And I cannot leave the dementia conversation without talking about caregiver education and support. Caregivers, like we just saw in the video, Mrs. S served as her husband's caregiver. They take a lot of strain from taking care of their loved one with dementia. And I think it's important when we discuss dementia that we include caregivers in that conversation always, 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 because the person with dementia doesn't always realize it. The person taking care of them always knows. And so it's very important for us to support them and educate them with different resources, let them know that it's okay to have various feelings about what they're watching their loved one go through. And just overall, when the caregiver is supported and taken care of, that means that the person with dementia gets the care that they need. And so my last dementia slide just talks about some different screening tools, and I won't dig too much into this, but there are different cognitive tests, so different screenings that we do. There are neuroimaging tests, so most likely an MRI, and then there are different lab tests. So when they run your blood or your urine, these are the types of tests that they might use to screen for dementia. Um, and what I will leave you with after talking about each D is this very strong point that dementia, when compared to the other two Ds, dementia is slow, it is chronic, and it is irreversible. And so that is the very big distinguishing mark when it comes to dementia. I think I will pause there. I don't see any questions, but I will pause on the dementia part if someone has any questions. All right. I'm going to move to Delirium next. Delirium is probably the most common presentation of all the things we'll talk about today. And the big word for delirium is confusion, disorganization. There's a change in the level of consciousness. Delirium is quick, it is acute, it comes on fast and strong and out of nowhere. Um, and fun facts about delirium that are always a little surprising, even though I've done this a few times. A lot of people experienced it, right? One of the big ones is around 30% of people who are in the hospital for anything may experience delirium. There are lots of incidents in long-term care facilities. Nursing home residents are often admitted to the hospital because of their experience with delirium. Um, a lot of cases, 2/3 of cases, are misdiagnosed as depression or dementia. And so that's another reason why it's important for us to talk through what these 3Ds look like and to make sure that we kind of understand what that presentation is, because misdiagnosis can lead to mistreatment, which can lead to a lot of other things. And the last one is that up to 85% of people who are very close to end of life experience delirium. So it is a very common thing. And it can be treated, it can be spotted. We just have to know what we're looking for. And so I'm going to play us another video to kind of give a preview of what this might look like in everyday.
Mrs. S is a retired teacher who is 84 years old. Her partner died 5 years ago, and she moved into a retirement home after suffering from a prolonged period of depression. She's been living in the home for 2 years. Mrs. S has mild hearing loss, osteoporosis, and a history of constipation. However, none of her conditions have stopped her from enjoying life. Mrs. S is a very social person who loves delivering the mail to the retirement home residents. Mrs. S spends much of her time with her best friend, Mrs. B, who shares many of her interests and has grown to be a great confidant. She enjoys reading to those with vision problems and plays the piano for sing-songs. As an active gardener, she takes care of all the plants in the residence, something she is particularly talented at. Recently, Mrs. S suffered a fall when she slipped on some water that she spilled on the floor. Unfortunately, her fall resulted in a fractured pelvis. Mrs. S was treated in an acute care unit and is now awaiting rehabilitation. When the other residents heard Mrs. S had fallen and was in the hospital, they all asked to visit her. But when the first visitor, Mrs. B, arrived, Mrs. S seemed very disinterested and didn't have much to say. After a few minutes, she turned away from Mrs. B and went to sleep. When Mrs. B left, she mentioned to the nurse that her friend was not herself. When the nurse entered Mrs. S's room, he noticed a lack of responsiveness. Mrs. S's meal tray was untouched, she had a furrowed brow, and was moaning softly. When she was asked to do some small range of motion exercises, the nurse noticed her movements were very delayed and slowed compared to the day before. It was evident that Mrs. S wasn't herself. The nurse assessed her orientation and found that she was oriented to name only. Her heart rate was elevated above her baseline. He called the physician right away and expressed his concerns about delirium.
Okay. So again, another quick preview of what delirium might look like. We saw that Mrs. S was this very active, engaged um, woman, and then she experienced a change in her physical health that sent her to the hospital. And while she was there and in her rehabilitation, she experienced some fast changes. This very active, engaged woman became extremely withdrawn. She became almost immobile. She wasn't eating. And so this presents as a hypoactive delirium, and it's really the slowdown. But there are three types of delirium. There's the hypoactive, which is what we just saw. There's hyperactive, and then there's a mixture of this. So hyperactive will look like restlessness, disorientation, agitation, aggression. I think the video did a really good job showing what a hypoactive delirium bout might look like. And then somebody with mixed delirium might experience both of these things. They might be really agitated at one moment and then completely withdrawn at the next. They might be really restless in the morning and then experience a very strong dip in their energy. So delirium can present in a few different ways. And I think, again, the video did a good job showing how quickly these symptoms showed up for Mrs. S and how it came about. So we'll talk a little bit about that as well. There are some risk factors for delirium. I think our video did a good job of mentioning that she was in severe pain, that she had experienced a surgery. So a drastic change in her regular everyday functioning. This is a quick list of risk factors. When it comes to medications, we have to be mindful of, are there new medications? Have there been changes to doses? Are different types of medications being introduced? Are we over medicating? Are we under medicating? All of that can kind of contribute to how delirium shows up. Also, infections. I know a lot of people think a UTI is probably one of the biggest indicators of delirium, and it is. But other infections like meningitis, pneumonia, sepsis, all those things can contribute to delirium. Having not enough water, not enough calcium, not enough magnesium, not enough sodium, all those nutrients that the body needs to function, if they aren't there, that can contribute to delirium. Again, the severe pain, changes in their bowel movements. Are they constipated? Do they have diarrhea? Have there been changes in their sleep? Are they sleeping more? Are they sleeping less? Has where they're sleeping changed? Are they overstimulated? Is it too loud? Is it too quiet? Is it too bright? Does it smell different for them? Sensory impairments, again, we'll start to see how some of these overlap, right? Is there hearing loss? Is there sight loss? Have they had changes where they can't eat the same way? And also drug withdrawals. Again, when we go back to the medications, have they been introduced to new meds? Are they withdrawing from an old medication? All of this can go into it. And a few others, if they are exposed to carbon monoxide or pesticides, if they experience a trauma like a burn or like Mrs. S who had a hip fracture, if they have a seizure or a stroke, anything that might lead to changes in the brain, including a TBI. In my little circle over here, I have risk factors that we can't change. So age, of course, is one of them. If someone has dementia, they may experience delirium. And again, if someone has a traumatic brain injury or any changes in their brain or their body, really, it could contribute to their delirium. The good thing is, knowing all these risk factors helps us figure out how to treat it. Again, there are medical and non-medical interventions that we can practice here. So, a big one that I like to talk about when it comes to delirium is assessing and evaluating what medications they may be on, if they have any infections, if they have any issues with going to the bathroom. And of course, we can offer them any types of medications. A lot of times we use antipsychotics or sleep aids to kind of help manage those changes in their mood and their sleep. But the other thing, along with these medications and evaluations, is to just make sure that their environment is comfortable, that we make environmental changes. So that might mean decreasing the noise. That might mean reorienting the person to the space that they are physically in. And a really big one when it comes to delirium specifically is setting a defined sleep-wake cycle, because that disruption in sleep, helping regulate their sleep, will help regulate their system and kind of get them out of the delirious space. Um, and of course, as always, there are screening tools. Again, I won't go through them, but there are cognitive screenings that we can do. A big one is to check their orientation, like the video mentioned. There are different lab tests. Again, a big one is the urinalysis because we often see it coming up with UTIs. And then, if needed, they can do a CT head scan as well. So there are screening tools for delirium, and I will leave you with my big point, which is that it is sudden and it is reversible. We have to do some screening, we have to check their meds, but this one comes in fast and it comes in strong, and there are plenty of ways that we can address delirium. So now I'm going to move to our last D, which is depression.
Ashley.
Yes, ma'am. Oh, I forgot. Yes.
It's okay. You have two live questions. One is from Ms. Braxton. She says, an internal medicine doctor told us that the study evaluating Aricept for effectiveness shown minimal improvement compared to the placebo. Are you familiar with those results?
Um, I am I am not familiar with those results, but what I will say to answer your question is there is a lot of debate within the medical world about the effectiveness of pharmacological treatment for dementia and Alzheimer's disease. So I'm not surprised that a doctor said that. I'm not surprised at those results at all. There is a lot of work going on in the pharmaceutical world to try and address these things, but there's a lot of unknown factors and there's a lot of studying that still has to be done. So I'm not familiar with that specific medication or those specific results, but they do not surprise me.
Ashley, would there be a good resource like the non-clinician could look at to keep up with studies regarding medications or a website of any type?
I would say I actually just met with a representative from the Lilly Corporation. And so I would say I would tell people to keep a lookout at your major pharmaceutical companies. Look at their websites, look at what they have going on. And I always will plug in the Alzheimer's Association does a good job of keeping updates about the new medications that come across.
Thank you, Ashley. The second question is from Stephen. Stephen asks, you mentioned that dementia is a leading killer, but you didn't provide any insight into how long sufferers may survive. Are there statistics about how long one can typically live with dementia or specific types of dementia?
That is a great question, and I will have to write that down moving forward. That is a great question. So it is not, it's not a quick death. And I hate to say it like that, but it's not. It is a progressive disease. And so most of the time, people receive a diagnosis in their late 60s, early 70s, but we can diagnose as late as 85, 90. I would say people live a rather long time with just dementia. Now, when we think about comorbidities, they may have heart disease, they may have cancer, they may have high blood pressure, they may have diabetes. Those other conditions can impact their lifespan because they're trying to navigate that along with their memory loss. But when it comes to dementia, the lifespan is progressive. So we have people who have early onset. We have people who get it. I think I heard about somebody getting it at 35 and now she's 50. So it's not one of those things that there's a instant ending. It just kind of progresses and gets worse over the lifespan. And as the older a person gets, the more likely they are to experience comorbidities that lead to that death. It's not necessarily the dementia itself, it's really that dementia weakens the body to fight all the other things that they may experience. So to answer your question in a short term, it's not a quick thing. It's a progressive disease and people can live 15, 20 years with it.
Thank you, Ashley, and thank you to our two attendees who asked questions. Again, a great time to remind, if you would like to ask a question, please put it in the question and answer chat, and Ashley will answer. And I appreciate you, Ashley. I will turn it back over to you.
Thank you. And thank you guys for those questions. I really, really like that. So we're gonna move to the last D, which is depression. Depression is probably one of the most common mood disorders, at least in the United States. And it is characterized by sadness and hopelessness and a lack of motivation. Typically, when people think about depression, they think about extreme exacerbated sadness. And so that's the definition that I like to use often. And of course, I can't leave you without some quick facts. Um, a lot of people don't like to talk about depression in older adults, but it does occur. 40% of people with Alzheimer's disease have depression. So again, remember I said the 3Ds can be cyclical, and this is one of those. Um, in long-term care facilities, about 35% may experience it. People who have other health conditions may experience it. And those who have depression may be at higher risk to have dementia later on. So again, that cyclical motion when it comes to the 3Ds is really big here. And so we're gonna watch another video. I think this is my last video for you guys about what depression may look like in our older adults.
Mrs. W. is a retired nurse living alone in an apartment. She is 83 years old and moved from the East Coast at her only daughter's request 1 year ago. As she doesn't see her daughter as often as she would like, she talks about regretting leaving everyone she knew behind. Her main social contacts are with the personal support workers, PSWs, and nurses who care for her in her home. Mrs. W. has macular degeneration, severe arthritis, and COPD. The visiting nurse has observed that Mrs. W's overall functioning has become more compromised in the last 2 months. She's struggling to go about her daily life, and because of worsening arthritis, she mobilizes much less than she used to. The PSW reported to the nurse that when he arrives in the late morning to help with personal care, Mrs. W is still in bed, with the curtains drawn. The apartment is quite cluttered and disorganized, with unpacked boxes still piled up in the living room. The nurse has asked Mrs. W several times if she is called to inquire about community resources and activities she might want to get involved in. Mrs. W just says she keeps forgetting the numbers. The nurse also knows that last month, the superintendent had to remind her to pay her rent. The nurse noticed Mrs. W has lost weight over the last several months. Her fridge is almost empty, and there are uneaten meals scattered around the kitchen. Concerned, she asks Mrs. W about it. Mrs. W tells them that the money spent on food is largely a waste because of her stomach problems. She quietly whispers that she needs to eat less anyway because she's afraid she won't have enough money to last for the rest of her life. The nurse asks Mrs. W about her mood recently, and she says she just doesn't feel motivated to do anything these days. She can't see the point anymore. The nurse and the PSW look at each other, both recognizing signs of depression.
All right. So our video talks about, I think the really big one here for me was those changes in her ability to remember or concentrate, and that decreased energy. She stayed in bed a lot more. Uh, she didn't necessarily identify the sad or the empty mood, but she did say that she wasn't feeling motivated. So there's the persistent sadness. There are feelings of hopelessness or helplessness. There are changes in someone's energy level, or that they just want to stay in bed. Another one is being irritable or restless. We didn't hear that in this case, but that often happens. She isn't interested in finding community activities, so losing that interest in being active. She's moving slower. She's had changes in her appetite. She's not having necessarily difficulty sleeping, but that is a symptom. And again, that difficulty concentrating and remembering. And we again start to see how these overlap with the other D's. And so these are, again, just some common symptoms of what depression looks like. But depression looks like it looks different for every single person who has it. And so this is a good presentation of what depression may look like. And I want to point out that she experienced a big change in life as well. And so being mindful of those big changes when someone transitions from a space that they're used to a new space, when they don't have the social support, when they're unfamiliar with that space, it can be depressing for some people. And so what causes depression? What are the risk factors here? The one that I like to focus on the most is social isolation and loneliness. I believe about last year, the Attorney General actually mentioned that social isolation is a public health concern. It is a big, big part of helping prevent depression, is keeping people active, keeping people connected. Another risk factor is not being physically active. Of course, there's social activity, but also that physical activity. And sometimes it can be hard if someone experiences a change. In one of the other videos, there was a broken hip. And so when someone loses their ability or their ability to move like they're used to changes, that can be a risk factor. Again, the sleep problems, stress, certain medical conditions, genetics can be a risk factor. And addiction can be a risk factor. And again, these aren't all the things, but these are things to be mindful of as we think about, is someone depressed? Might they be experiencing depression? Let's think about, have they experienced some of these things? And yes, there are treatments for depression. These are probably the most simple out of all of them. There are antidepressants that can be prescribed, and then there's psychotherapy. And another one that I don't have listed here again is keeping people socially active, keeping people engaged, keeping their brains and their bodies active, being out in nature, being with other people really is sometimes one of the best ways to address depression in people. And again, of course, there are ways to screen. As a social worker, one of my big ones that I like to consult is the geriatric depression scale. There are other scales that we can use to assess depression. There are different lab tests, and again, there's the MRI. So always know that there are ways that we as health professionals and you as family members can advocate for some of these tests and screening tools as well. And so what's the big takeaway from this one? that it is reversible. Again, there are treatments, there are things that we can address and look at, and this is about, so dementia is slow and progressive. Delirium is fast and sudden. Depression is in between there, right? There are changes that persist over 2 or more weeks. And again, they are reversible changes. But being mindful of that time period is what I really want to emphasize when we talk about what do the 3Ds look like and how do we differentiate between them. And so now that you have heard and seen all the different examples and symptoms and treatments of the 3Ds, I like to summarize it. And this chart, and there's a second page to this, but this chart tries to simplify those differences for you. And again, my biggest emphasis about differentiating between the 3Ds is that onset. Was it sudden? Was it gradual? Have you noticed it over weeks or over months? Um, and how we treat these things. A lot of treatment, of course, there's always medications available. It might be to treat the disorder, it might be to treat the disease, or it might just be to manage those symptoms. I think a really big part of treating any of them is making sure that the caregivers are educated about what it looks like and the best way to approach the person that is dealing with these things. And so the next page kind of goes over more of those symptoms. And I won't dig too much into this because we talked about the changes in how someone thinks or functions. And all 3Ds come with changes in cognition. They come with confusion sometimes. They come with memory loss sometimes. They come with changes in concentration. Um, all of them can be caused by disruption of sleep or have an impact on how someone sleeps. They can have an impact on someone's mood and their personality. And they can have an impact on how restless someone is, how agitated someone is, how motivated someone is. And I will put in the chat before I leave today, there is a more detailed chart. This is a very summarized chart, but there's a more detailed chart that really breaks this down further than the thinking, further than the sleeping. It gives you the same screening tools I've mentioned before. So I will make sure that I put that in the chat. And so I want to make sure I leave time for a few questions. Again, why do we talk about the 3Ds? They have shared risk factors. Again, someone's age, someone who is experiencing changes in their sleep and appetite, all those things are risk factors for all 3Ds. They all may present similarly. Again, those changes in sleep, how someone is thinking, their mood, how isolated or engaged they are. And finally, and I think we've seen this throughout the presentation, is that they can feed into each other and really feed off of each other. So it's very important for us to understand the 3Ds and what they look like, and really that um, we can make a difference in no matter which one is presenting. And so I'm going to run through this really quick, um, how to work with the 3Ds. The first thing is to evaluate the environment. And so here I have a list of questions, but really it's about making sure if this person has changed environments or changed homes, is it comfortable for them? Is it distressing for them? Have they experienced changes in their health? Our example from earlier is a hip replacement or some damage with her hip. So really being mindful about what the environment looks like, sounds like, smells like. Is this person comfortable? Has all their needs been met? Going back to our first slide, have we met the needs in the way that they want them to? Um, and the one that I want to point out the most is not only evaluating the patient, but also evaluating ourselves. We can have specific bias about certain diagnoses. Dementia is very scary. People don't want to talk about it. People don't know how to address it all the time. Delirium is scary because someone who was calm last night and now is super aggressive, that can be off-putting. Someone with depression, that can be overwhelming because you want to help them and you may not know how. So I like to tell people evaluate the patient always, but also evaluate yourself and your beliefs about the 3Ds and about older adults. Um, because we have biases and we have to be mindful of them while we're treating our clients and our patients, while we're working with our family members. It doesn't mean that you're the worst person in the world if you have specific beliefs. Just be mindful of them in your work and as you work with these people. The next one, again, I'm, of course, as a social worker, as a healthcare professional, medicine is there. It does exist. There are other ways to help our patients and our family members be comfortable, making sure that they feel safe and secure wherever they live, minimizing noise, making sure that the light isn't too bright, making sure that they stay active, whether that's physically, spiritually, cognitively, um, making sure that people are comfortable is really the big part here. Making sure that their privacy is respected, that their body is respected, that their wishes are respected. Really making sure that the environment is what they need to be comfortable. And one more, when you communicate with people is very important and how you communicate with people. And these tips are really, they go for all the 3Ds. They're pulled from dementia, but they go for all the 3Ds. And I won't read all of them to you, but just be mindful of using short, simple sentences. Instead of open-ended questions that can lead to confusion and frustration, use yes or no questions. Be patient. And I know that can be very, very hard, but let people talk it out. They don't remember the words that they're looking for. Help them walk around it. Um, Again, just be mindful that people experiencing all 3Ds and especially dementia have had big changes in their brain. And so they don't always remember. They don't always know, even if you think that they should. And so giving them the space and meeting them where they are is extremely important when we communicate with anyone with any of the 3Ds. And then my last slide is just a list of resources. And again, I'll drop that link here for you. And to finish up, because I could not finish without talking about the Virginia Memory Project. Like I told you, it is Virginia's dementia registry. And so what that means is we keep track of anything dementia, Alzheimer's related. We get some of that data from the state, and then we get some of that from people who take our survey. So there's the data component, and the data is really important because it drives how people get the money to treat these things, how people get the resources to treat these things. But another part of the Virginia Memory Project, and the part that I am most excited about, is that we stay connected to the community, that we listen to the community, and people who experience dementia get to come to us, they get to talk to us, and we go to them too. A big project that we work on is the Altar Project, and that is where we go to African American churches and help them ensure that their congregation is dementia ready. So that might be shorter sermons, that might be having rooms for respite, that might be different music or just programming or just education, which leads me to the next point is that we like to give education. We want to come talk to you. We want to come talk to your friends, your family, whoever. And we want to keep people connected to services in whatever way we can. And so I will stop there because I know that that was a lot of information. And I just want to say thank you for giving me the space to share all of that.
Ashley, that was amazing information. You have one more question. Um, the question is, our family member with vascular dementia, not Alzheimer's, was prescribed trazodone for sleeping and depression, but it caused nightmares and he abruptly stopped it. He's against medications because of the side effects. He is inconsistent with activities. Sometimes he wants to go out, other times he wants to stay in and go through papers to throw out. Suggestions on getting him consistently engaged. I think it's typical to have waning interest.
It absolutely is typical to have waning interest. What I will say is you might want to consider building a routine, building a schedule for that person. And I know that that can be hard because they might not want to follow that schedule. But I think that's one way that I've heard families kind of navigate that waning is if they create that schedule, then it gives the person with dementia some type of structure and something to look forward to. And I'll go back to the trazodone point. A lot of people struggle with the side effects of medication, which is why I always like to offer the non-medical interventions because it can be hard. It can be hard to adjust to psychiatric medication. And so, what I would suggest is going back to the healthcare provider and letting them know what type of side effects he's experiencing and see if they can change the dosage or change which medication that they're on. It sounds like it was prescribed for depression and for sleep. So, maybe there's another sleep alternative that they can give them, but I will say that it's a very common experience. I spent some time in inpatient psychiatry, and a lot of our people did not want to take those medications because the side effects can be heavy for a person. I'm glad they have that option. I wish I had more to offer on how to make them adherent to that, but it really is a fine line and a struggle when it comes to psychotropic medications. So I wish you the best of luck and really reevaluate that medication.
Well, and our last comment in the question and answer, I think, sums up what we all say thank you. This was very informative, Cindy said. We had another anonymous Cindy said, thank you. You have been so helpful. Again, you are a wealth of knowledge. We appreciate you being a part of our UI Informed. You brought exactly what we love to bring to our residents and families and the community surrounding us, an expert to answer those questions, have the discussion. And I think that's what I heard from you today. There are resources, there are people that are willing to educate, and there's a lot of ways and things that definitely BCU offers through their geriatric programs too. So thank you for putting those resources in the chat. I want to again thank each and every one of you that have attended for the first time, or if you are a regular attendee. We thank you for being a part of Retirement Unlimited Incorporated series of just aging well. And we want to continue to bring you experts. So we hope you join us next time. Again, please help me thank Ashley Staton, our expert for this evening. Thank you each for your individual time and attention. Have a great night and join us next month. And we're looking forward to provide you more information about vision and how we can help with that too as well. Thank you, everybody. Have a good night. Thank you,
Thank you.
Ashley.